Good evening, ladies and gentlemen. I would like first to thank the organizing committee about the invitation to be in this special congress, and the president, Mr. Makrigiannakis. And I want to apologize that not to be there because due to the weather today, we had a very big problem in the airport of Creta. So we are from far away here about our satellite symposium about the social egg freezing, necessity or modernism. So I would like to invite our speaker, George Christopoulos. Is senior lecturer in United Kingdom and is working now in one of the biggest centers of IVF in Greece, IVF Embryogenesis, about the presentation of this topic. George?
Thank you, Vasilis. Let me firstly extend my own gratitude to Professor Makrigiannakis and the organizing committee for the kind invitation at this symposium hosted by Fertiland. Also, let me extend my apologies as we've had a very eventful morning. An airplane half full with gynecologists made it to the air of Heraklion, but then we had to fly back as the weather didn't allow us to land. However, we'd still like to go on, as the topic of this satellite symposium is to discuss whether social egg freezing is indeed a necessity or an act of modernism. Now, I'm happy that this meeting is chaired by Vasilis Kelaris, who has been the co-founder of the Believe organization, an excellent group of people that are trying to help the Greek population increase through the provision of free IVF for unprivileged women and couples throughout Greece. And the reason I'm grateful is because we seem to live as a generation in quite a demographic shift. And if we look back at 1975, the average age of a woman in her first pregnancy was 27. This has increased to over 30 years old for the first time in 2015. And that was the first year in England and Wales where more than 50% of all live births were actually reported in women over the age of 30. More worryingly, 30% of the total population seem to have their first child after their 35th completed birthday. So ultimately, discussing social egg freezing is very relevant given this demographic background. Now, what do these three gentlemen have in common? Mick Jagger, Pablo Picasso, and Rod Stewart, very different gentlemen indeed, but what they all have in common is that they fathered a pregnancy, they became fathers over the age of 70. When they were all asked why or to make a comment, they all responded with the same three words. Well, they said, it's never too late. In comparison, this slide is by far more attractive. But still, these three women, famous Hollywood actresses or singers, Maria Menounos, Sofia Vergara, and Rita Ora, although they were on average 40 years younger than their predecessors in their previous slides, were convinced or decided to freeze their eggs in their early 30s. And what they also jointly answered when they were asked why is not that it's never too late, but the exact opposite, that it's never too early to freeze your eggs. And they're not alone. In most parts of the world, and in particular, the English-speaking world, the UK, the US, Australia, and New Zealand, all countries have experienced an almost parallel steep rise in the fertility preservation methods through egg freezing. Just in the United States alone, a 9-fold increase between 2010 to 2016, going from approximately 1,000 cycles to nearly 10,000 cycles of women having egg freezing for non-medical fertility preservation every year. And although we're lagging behind in this curve, I would like to assure you, based on our own experiences at least, and I imagine many of the audience will agree, we are experiencing this paradigm shift where more and more women will present in IVF centers seeking to freeze eggs for what we call social reasons. Now, this has opened clinics to more patients, but at the same time has paved the way for more criticism. And going back to the Daily Mail, almost 10 years ago, publishing an article about how IVF clinics are peddling false hope over egg freezing, with a huge expose on many IVF units across London, where the doctors apparently were told that who told our patients that the chance of delaying motherhood and getting pregnant through egg freezing exceeded 65%. Is that false hope? That's what I want to discuss today. Or is this actually very close to reality? Now, let's not trust doctors or journalists about what women think. I think we should be asking the women themselves, what do they think about egg freezing? And again, over the course of years, we have seen a definitive increase in the number of women that would actually consider egg freezing. So these are population questionnaire-based studies. Going back to about 10 years ago, about 1/3 of women would then consider egg freezing in Belgium for women aged between 21 to 40 years old. This increased to nearly half, 46% in 2016. In 2017, 5 years ago, almost 3 out of 4 women of the general population of reproductive age would answer that they would definitely consider egg freezing as a method of fertility preservation. So this trend has definitely caught on with the women in the community. What do women think? Well, when they were asked by a scoping survey by Yvonne O'Brien and her colleagues in the UK, women answered that egg freezing is an excellent option for all women in about 60% of cases, whilst 60% of women also quoted that it is the woman's right to postpone pregnancy and freeze eggs. And only 25% of the general population felt that egg freezing should only be offered for medical reasons. So social egg freezing, a very contemporary matter, which really involves the whole of the population throughout Europe. Women don't just need egg freezing. Overwhelmingly, they answered that first and foremost, they need education and they need diagnosis. So many women clearly answered that. In 65% of cases, women would be interested to check their ovarian reserve, regardless of whether they had started a family or not. 70% would be very happy to pay for a test that costs 60 euros to check their ovarian reserve, whilst a very interesting 55%, more than half, answered that all women should be offered an annual test of their ovarian reserve, very similar to having their pap smear every year at their gynecologist. One second, there we are. Who are these women, we ask? Now, if we look at the observational studies by Cobo in Spain, who have led and have been at the forefront of egg freezing around Europe, we notice that the majority of women, 63%, are aged between 36 to 39. 3 out of 4 are single heterosexual women, and 72%, again, 3 out of 4, are of college or university education. And these are exactly the population where these publications and these news agencies aim for. These are 2 protocols which I personally strongly disagree with. Freeze your eggs, Bloomberg tells us, to free your career. And that egg freezing is not just insurance, it's eggsurance. Having in the background a strong, beautiful, powerful, successful woman, almost implying that in order to achieve this, a woman needs to or should really consider freezing her eggs, trying therefore to separate success in the professional field with success in the private field. And that, I think, is the wrong message to send out. Again, we should ask women. Women don't agree. So overwhelmingly, the most important reason of why women decide to freeze eggs in 88% of cases is the lack of an appropriate partner for them to start a family, with only 24% answering that they chose to do so for professional or financial reasons. Now, a bit of background about egg freezing. Well, even with the advent of vitrification, we need to acknowledge that oocytes are single cells. We're not freezing blastocysts of 120 or 140 cells, but instead we are freezing single cells, which are notoriously difficult to cryopreserve. As they have a low surface area to volume ratio, they do have a high susceptibility to intracellular ice formation in the ooplasm, whilst we all know that if we're going to throw an egg, we must employ the use of ICSI due to the hardening of the zona pellucida, which would make traditional or routine IVF very difficult. What did we think 10 years ago? 10 years ago, we weren't recommending egg freezing as leisurely as we're doing now. The Royal College of Obstetricians and Gynecologists in the UK clearly stating that the chances of a healthy pregnancy from a vitrified oocyte are small, 4%, whilst the National Institute of for Health and Clinical Excellence makes absolutely no mention about elective egg freezing or banking. With our friends across the Atlantic, the ASRM also agreeing 10 years ago that there is a 4% live birth rate per oocyte thawed, and hence this method should not, still remains a highly experimental approach, which should not be offered routinely to women. A lot of things have changed in the last 10 years, however. And the first thing that I wanted to mention is the first RCT published in this by Parmigiani back in 2011, where they did something really, really clever. Women that had IVF using their own eggs and their partner's sperm were randomly allocated to having surplus embryos cryopreserved or surplus eggs cryopreserved so that they would have ICSI with their subsequent cycle. What did they show? Well, similar outcomes, as they reported a 35.5% clinical pregnancy rate per cycle started, very similar outcomes in women that chose to transfer frozen blastocysts or thaw embryos and fertilize them with sperm. Now, this is the largest study, the study from Cascante et al., where they actually published on 15 years of autologous oocyte thaw outcomes from a very large university-based fertility center. What did they show? Well, 543 patients who underwent 800 oocyte cryopreservation cycles with a median age of 38.3 years old. I would argue very similar to the population of people that we see, with a very interesting median time from egg freezing to thaw being 4.2 years, which also explains a lot about how much time should we expect these patients to wait before they knock on our door. With a average number of thawed eggs being 12, and very importantly, an overall survival rate of all oocytes being 79%, and this is the real world. Thawing oocytes and thawing blastocysts is a different game, okay? Freezing and thawing blastocysts, we expect any reputable center to be able to report a 96 or 97% survival rate, whilst with thawed oocytes, the median survival in this study was 79%. So they did something interesting. We use this example a lot in our counseling sessions. For all age groups, the final live birth rate per patient after thawing the eggs and fertilizing them was 39%. Many would argue similar to having fresh IVF. For women less than 38, 51% final live birth rate, again, similar to the IVF population for the same age groups, with 34% of women between 38 to 40 having a live birth, and as expected, a smaller, but I would argue very decent, 23% for women who decided to freeze the eggs at the age of 41 or older. But are two 38-year-old women the same? As we all know, no, they're not. So a great deal of success needs to be correlated with the number of eggs that we collect. And again, going back to Cobo's paper from Spain in 2016, what the researchers did is they looked at individual live birth rates per number of eggs collected and per age group using a binary system. So for women less than 35 years old, 5 eggs will give you a 15% live birth rate, whilst 15 will give you an 85% live birth rate, which I would argue is very acceptable as a method of fertility preservation. When the age increases, 5 eggs will give you 5.1 LBR, with 11 eggs seeing a sharp decrease compared to this 85. 35% of older women would be able to give us a live birth. So the number of eggs and the date of birth of the woman actually being by far the most important prognostic factors in the outcome of this treatment. All these data have thankfully led both the Royal College in the UK as well as ASRM to issue new guidelines. So the practice committees from the American Society of Reproductive Medicine and SART, the Society for Assisted Reproductive Technology, have issued a joint statement where egg freezing, mature oocyte cryopreservation should no longer be considered experimental, although there is not yet sufficient data to recommend it for the sole purpose of circumventing reproductive aging. A rather nebulous description, but the message to take from them is that this is a method which they have assessed and now deemed to be both efficacious but also safe. Now, we need to remember, these are not patients. These women come to us primarily as clients because they have no medical problem. They're here subjecting themselves to a medical intervention, a tedious and lengthy medical intervention for purposes of preserving their fertility. So our aim is to treat them as clients, and our aim should be to provide them with the easiest possible protocol for the shortest duration with the easiest medication to use, avoiding expensive wastage of medication. And what we have shown, and what has been shown with a Foxon 2018 study, is that we can decrease wastage of medication if there is no dose alteration and the optimal dose is used from the outset. Hence, we need to ask ourselves, do we really need to manipulate the dose on a daily basis, particularly for women that are seeking to have fertility preservation? How important is the initial dose? That is what we argue the most important step in this process. And indeed, what we do know is that when it comes to pharmacodynamics and pharmacokinetics, the pharmacokinetic effect of recombinant FSH is not reached until you have 4 days of repeated daily subcutaneous administration. Hence, should these women be having different doses every day? Our argument is not. The easiest the method, the better the compliance for the patient. On top of that, when we look at the pharmacodynamic studies, what we see is that even after you reach your peak concentration of FSH, the outcome, the pharmacodynamic outcomes of this still have 4 further days of lagging. So it becomes more evident that a stable dose of an appropriate starting dose of medication should be the way forward for these patients. Speaking about safety, the last thing we want is for a patient/client coming in for fertility preservation and going home with loads of eggs and ovarian hyperstimulation syndrome. The GnRH agonist trigger has been pivotal, has really changed the way we practice. As Professor Messinis previously clearly noted about PCOS patients, but we can extrapolate this and use GnRH agonists for most, if not all, patients having egg freezing. Matini Elodromiti in Edinburgh and our research team in London were able to report on the 2 largest observational studies where GnRH agonist trigger was associated with a 0.3% severe HSS patients for a severe HSS rate in the highest of high responders. And both Paul Devroy and Professor Okta in New York both reported that GnRH agonist trigger and cycle segmentation essentially what we're doing with egg freezing is associated with a nearly 0% of ovarian hyperstimulation. What about the opposite, though? What about poor responders? Now, that's a difficult discussion to have. And I'm sure all of us, or most of us in the audience in Crete and here in Athens, have experienced this. The 38-year-old woman with an AMH of 0.3 presenting to cryopreserve her eggs. And that's a difficult discussion to have. A, should we proceed? And B, what should we do? A lot of talk has been made about the Duostin protocol, which all of us are familiar with, a protocol that has been used for IVF patients seeking to have embryo transfer in the future. Amazing protocol. It works really well. Our concern is that the acceptability of this protocol in women seeking to freeze her eggs is difficult, because you have a client that comes in to freeze eggs looking for the easiest approach and ends up having IVF medication for the best part of 1 month. Our experience has not been great, but we have certainly used it in cases of medically required oocyte cryopreservation in poor responder women that were scheduled to have chemotherapy or gonadotoxic treatment or even surgery for endometriosis in the near future. A question I'm often asked, and I imagine many of us are asked in the audience, is how many eggs do I need to have a 100% chance of making this work? Now, the researchers in Harvard built a mathematical model where they looked at average fertilization rates, average blastocyst formation rates, average implantation rates in different age groups, and came up with these industrial numbers. I can't see their faces in the audience, but I can share that I laughed when I saw these numbers. To achieve a 100% live birth, you need to give a 35-year-old woman 40 eggs, a 38-year-old woman 80 eggs, and a 39-year-old woman 100 eggs. And women need to know this. This is not eggsurance or insurance. This is simply an efficacious and fairly powerful tool to help promote fertility preservation, but it's not panacea. It will not guarantee a pregnancy in the future. Now, let's go to the other end of the mirror, to the opposite side, when a woman knocks on our door and wants to use her eggs. At Hygge IVF, we select to freeze eggs in groups of 3 or 4, because we like to give patients autonomy to select how many eggs they want to thaw. And very often we've had women that have come forward with one partner and then decided to come in with another partner in the future. So having eggs frozen in little batches helps. But if the answer is, how many eggs do we need to thaw to achieve the optimal live birth with 1 egg freeze? The answer is all of them. So the more eggs we thaw, the better the outcome with a live birth rate from the first embryo transfer, as I'm sure we will all agree. Are children born through vitrified oocytes normal? Yes, they are. We haven't seen any significant changes other than 2 interesting things. One of them, the increased incidence of urinary tract infections. I believe it's an incidental finding, and very clearly an increase in the number of cesarean sections. I believe this is age-related rather than oocyte thawing related. These women may present at a later stage. These women might treat their pregnancy as a more precious and final pregnancy, so it is to a great extent patient-led and iatrogenic. Welcome to the new age, fertility for millennials. I felt very old when I looked at this because I had no idea that something like this exists. On the cover of Forbes magazine, you can see Martin Warwawski, a half-Polish, half-American prodigal entrepreneur from the Silicon Valley, a billionaire amongst billionaires who decided to dip his toe into the field of IVF. So he set up Prelude Fertility, a 200 million startup, which did something really clever. If you want to freeze your eggs under Prelude Fertility, you pay for nothing. if you want to use your thawed eggs after 3 years at least to get pregnant, you pay for nothing. But what they do is they have a monthly rate of more than $200 for the time that you freeze. And this is something that has become exceedingly popular in the States. So many women, young millennials in the state, may freeze their eggs and have a annual or monthly storage fee until they decide to use them. What about if you work for Facebook, Google, or Apple? Well, these companies, at least if you live in London, will provide you with a 20,000 euro budget for fertility preservation in the future for you to do anything you like with it. And the question here is, does this company-sponsored egg freezing promote women's autonomy, or does it confine it? Well, on one hand, the supporters of this method say that it counters the concern for exploitation. It expands the reproductive autonomy of women. Women no longer need to worry about juggling a career and egg freezing, so they can actually extend their fertility further. And also, it allows single professional women to freeze their eggs when they're younger. On the other hand, oocyte cryopreservation might actually fail to empower these young women because it might disempower them by overtly stating the very subtle message that women who have babies are not serious about their careers. Utter rubbish. So a lot of critics about this company-led and induced free fertility preservation have stated this comment. Now, it is not whether egg freezing is paid by your company or by yourself, but social egg freezing. Does it obscure the influence of contributing social structures? Should we instead be testing women, having better access to oocyte, to ovarian reserve testing, and allow women to actually get pregnant sooner without giving them mixed messages? And the answer, I believe, is yes. And a question for the audience and all the professors in the audience, or anyone who might oppose fertility preservation through egg freezing. We have all, I imagine, treated a 45-year-old woman, a poor responder with 1 or 2 eggs, seeking to have a natural or mild stimulation cycle under our care. So we've all done it. And the question I would like to pose to the audience is that decision somehow more moral than allowing a woman to freeze her eggs at the age of 30 and then be allowed to postpone maternity up to the age of 40 or 45? Well, actually, I don't believe that is the case. I think egg freezing is a really, really powerful tool. And this is where Fertiland Pharma have introduced this worthwhile campaign, η σωστή στιγμή, or isostistigme.gr, a fertility preservation campaign which is supported by Gideon Richter. It provides information and support to women considering egg freezing, and has been inspired by the rise in interest and the discussion around social egg freezing, the myths and the realities of this otherwise very, very powerful tool. So to conclude, egg freezing, necessity or modernism? The answer is neither. It is another instrument that can help women. It is another very important tool at our disposal that should be based on appropriate information, education, and ovarian reserve testing for the general population. Thank you very much.
Thank you, George. Thank you, George Christopoulos, about this excellent presentation. We're very happy to hear all this value information. I don't know if we can have any questions from the audience now. Anyone who wants to ask something, Mr. Christopoulos? I think there's no question. So would like to thank the organizing committee again, Professor Makrigiannakis, for this invitation about this satellite symposium. I would like to thank also George Christopoulos, an excellent colleague, an excellent friend, about his good words. And we would be happy to see you again in another symposium, but to be there also with you. We are very, thank you very much.
And stay safe with the rain. The news are showing cars drifting into the sea, so I hope everybody stays safe.
Thank you very much, everyone.